Glasgow Coma Scale is a neurological scale used for assessing a person's conscious state objectively. The scale uses three main responses, which are eye, verbal and motor response, and is scored out of a total of 15.
Eye response is scaled out of 4. Assessment of eye opening involves evaluation of arousal and being aware of the environment. A patient will receive a 4 if they have spontaneous eye movement. For example, if the patient looks at me when I walk into the room. The patient will receive a 3 if they only respond to speech. Julia, can you open your eyes for me? A patient will receive a 2 if they only open their eyes in response to pain. This can be produced by putting pressure on the nail beds. A patient will receive a 1 if there is no response after numerous attempts. Julia, can you open your eyes for me?
The patient is asked a series of questions to test the best verbal response. These questions will test how orientated the patient is to the environment. Do you know what your name is?
Julia.
Do you know where you are, Julia?
Hospital.
Do you know who the current Prime Minister is?
Julia Roberts.
Okay. Do you know what month of the year it is, Julia?
August.
What year were you born?
85.
Okay, that's right. Speech should be spontaneous and specific to conversation. So the patient is scored on a scale of 1 to 5. 5 being the best score, the patient is orientated and able to converse. In this instance, the patient was a little disorientated and confused, but was able to talk. Therefore, they scored a 4 for best verbal response. So if the patient received a 3 for a score, they would have inappropriate words. If they received a 2 for a Glasgow Coma score, their words would be incomparable sounds. And a 1 is no response at all.
Motor response is scored out of 6. Assessment of motor response is designed to determine the patient's ability to obey a command. A patient will gain a score of 6 if they obey a command for movement. For example, can you wiggle your fingers, Ashley? Okay. A patient will gain a score of 5 if they have purposeful movement to a painful stimulus. For example, if I press into the nail bed and Ashley swaps my hand away. A patient will gain a score of 4 if they withdraw from painful stimulus. A patient will score a 3 if they have a decordicate response. For example, their arms are adducted with flexion of the elbows, wrists and fingers, as well as hyperextension of legs and plantar flexion of feet. A patient will gain a score of 2 if they have a decerebrate response. For example, if their arms are stiffly extended, adducted and hyperpronated. The hyperextension of legs and plantar flexion of feet.
Abnormal posture such as decordicate or decerebrate response, where there is involuntary flexion or extension of the arms and legs, is an indication of severe brain injury. It occurs when one set of muscles becomes incapacitated while the opposing set is not, and an external stimulus such as pain causes the working set of muscles to contract. The posturing may also occur without a stimulus. Since posturing is an important indicator of the amount of damage that has occurred to the brain, it is used by medical professionals to measure the severity of coma with the Glasgow Coma Scale for adults and the pediatric Glasgow Coma Scale for infants. The presence of abnormal posturing indicates a severe medical emergency requiring immediate medical attention. Decerebrate and decordicate posturing are strongly associated with poor outcomes in a variety of conditions. For example, near drowning victims that display decerebrate or decordicate posturing have worse outcomes than those that do not. Changes in the condition of the patient may cause him or her to alternate between different types of posturing.
When assessing pupils, you are looking at the size, shape, reactivity to light and comparison of one pupil to the other. Both pupils should be the same shape, size and react equally to light. Normally, both pupils are the same size, between 2 and 6 millimeters. Pupils can be described according to their size in millimeters or by description, for example, pinpoint or dilated. Pupils are normally round in shape, but there are some abnormalities that can be seen, such as a void. To assess the reactivity, bring a pen light in towards the eye from the side of the eye towards the pupil. Normally, pupils briskly constrict to light and briskly dilate when light sources are removed. Abnormalities that can be seen are sluggish, which is slow constriction of the pupil and is found in conditions that compress the third cranial nerve. Non-reactive or fixed, which is when the pupil does not constrict to light, which is also seen in conditions that compress the third cranial nerve. Evaluation of pupil reaction is effectively an assessment of the third cranial nerve, which controls constriction of the pupil.
In a neurological assessment, it is important to assess the strength of the patient's limb, including their arms and legs. This is done by asking the patient to squeeze my hand, and then push my hands away, and then pull my hands towards you. And then same with the legs. Push your legs out towards me, and then pull down. You're assessing the amount of weakness found in the legs. This may range from mild weakness to moderate weakness, and then to severe weakness. You're also checking to see if there's any strength differences within the arms and legs.
Pediatric GCS is the children's equivalent of the Glasgow Coma Scale for adults. It's used to assess the mental state of an infant. As many of the assessments on the adult GCS would not be appropriate for infants, the scale was slightly modified. The score is still out of 15 and it is still comprised of the 3 categories of eye, verbal and motor response. The difference is that the scores will be dependent on a child's age and their intellectual ability to respond appropriately.
If a patient's GCS begins to fall in a hospital setting, the MET should be called. The patient's airways need to be maintained and oropharyngeal may be used for this. Ensure that suction and oxygen are available. Put the patient on their side in case of arrest and monitor oxygen saturation levels. Monitor observations such as blood pressure, heart rate, pulse and temperature. Check the pupils are equal and reacting to light. Perform an echocardiogram. Attach a heart monitor and regularly monitor neurovascular observations.
I will discuss with you today the importance of monitoring vital signs as part of neurological assessment. This piece in particular will focus on management of stroke patients. Vital signs of a suspected stroke patient is monitored 15-minutely for the first 6 hours. Stroke is defined as a neurological deficit lasting 24 hours or more. Early recognition of the signs and symptoms are important to maintain the brain's perfusion. This is known as central perfusion pressure. Blood pressure elevations are commonly seen in stroke patients. Blood pressure must be maintained artificially through the use of medications to ensure that the intracranial pressure is maintained adequately. Generally speaking, as uncontrolled blood pressure rises, intracranial pressure increases. If the MAP or the mean arterial pressure exceeds the intracranial pressure, the brain will be deprived of blood entering, and this can lead to cell tissue death, also known as ischemia. The mean arterial pressure is the average arterial blood pressure during one single cardiac cycle. The normal range is 70 to 110 millimoles of mercury. A MAP of 60 is required to perfuse the brain, kidneys and coronary arteries. The goal for ischemic stroke is to maintain a systolic blood pressure below 220 millimoles of mercury and a diastolic less than 120 millimoles of mercury. So the goal here is to gradually lower the blood pressure by 20% increments. This is to prevent enlargement of the infarctive area. It is also very important that the respiratory pattern is closely monitored to ensure that the stroke does not extend, with the patient incurring further neurological damage.
It is common for patients that have experienced a stroke to suffer from hypoxemia. However, this is often due to complications such as aspiration, hyperventilation, or pneumonia. As nurses, our primary goal relates to nursing the patient in a way that will prevent further neurological deficits. Time is critical. As temperature increases, the patient will become febrile and the hypothalamus can also become ischemic. A subsequent consequence of uncontrolled intracranial pressure is the Cushing's triad response. Three components of this are: 1. The pulse pressure widens and the patient becomes bradycardic. 2. Uncontrolled hypertension leads to significantly higher intracranial pressure. 3. The patient's respiratory rate and effort become irregular. Respiration slows down. And at this point, herniation of the brainstem is impending, and this can potentially block off blood flow. So if the patient does not receive adequate intervention, cerebral ischemia, or ultimately infarction, brain cell tissue death can occur if left untreated.
Documentation is an important part of a neurological assessment to ensure all assessments are recorded and neurological progress can be monitored. To fill in the neurological documentation, you put a dot next to the score the patient received for eye response. If the patient is unable to open their eyes due to swelling, you mark it with a C. For the best verbal response, you put a dot next to the score the patient received. If the patient has a tracheotomy or an endotracheal tube, you mark this section with a T. For best motor response, you mark a dot next to the score the patient received, and you take the result of the best arm response. To document pupil reaction, you put the size of the pupil the patient received in relation to millimeters, which is in the scale on the provided documentation sheet. Next to reaction, you put a plus sign if the pupil reacted briskly, an S if the pupil reaction was sluggish, and a negative sign if the pupil did not react, and a C if the eyes were closed and you were unable to complete a pupil assessment. To document the limb strength, you put a black dot next to the correlating result the patient received. If the right and left arm received different results, you put an R to mark the result of the right arm and an L to mark the result of the left arm. You also document all the vital sign observations on the neurological observation sheet. This documentation keeps a record of all neurological assessments completed and gives an accurate overview of the patient's neurological progress. It is important to complete a neurological assessment with the next staff member taking over the care of the patient to ensure all assessments are being carried out the same and staff members are documenting the same results to ensure continuity.